Rod, welcome today, and we'll get an update from you if you don't mind. Thank you very much.
I got it. Can you hear me?
Yep.
Awesome. So at the moment my PSA is at 0.16, so it's come down a fair bit. Still have cancer on some of the bones, such as the pelvis, the ribs, and the femur. So I feel a fair bit of pain, especially in winter, really bad. Other than that, still on the same medication that they've had me on. They listened to me about the pain medication finally, so they give me enough to last me 28 days. That's basically it.
For people that haven't heard you before, Rod, could you just tell them what medication you're actually on, and
Yeah.
if you wouldn't mind? Yeah.
I'm on. You have to mind. I can't pronounce most of the stuff I'm on. Degerolix subcutaneous injection.
The
Dex.
Garolix.
Pardon?
The Garolix.
The Garolix, so it is. Yep. Docetaxel. Lucrin. And enzalutamide and denosumab injection monthly. And I'm on Tarjan painkillers, 1 in the morning, 1 in the afternoon. And I have endone, 2 a day, which is a nightmare. That's the drugs that I'm on at the moment. I don't do chemo. I did chemo once, and I had 1 radiation shot once.
Do you mind telling everyone how old you are, Rod?
56.
56. And you've been on treatment for?
Since
how long?
2021. 2021 I was diagnosed.
Right.
And I've been on that. I was on a different hormone drug, one that I had to do monthly. It was really strong. So we dropped it back to Lucrin, which is a little bit weaker, so I wouldn't get used to the ADT drug. And when I went on to Lucrin, my PSA went up. So I had to go take that enzalutamide to get my PSA down again. Enzalutamide is a bone medication, and the Danoslab, which I do monthly, is a bone injection, or an injection for the bones as well.
The denosumab, you were going to go
Denosumab.
off it at one stage for a while because you'd been on it for a fair while. Have you gone off it at all, or do you still have it each month?
Still have it each month.
You do, right.
But my issues are, which is why the endone was a nightmare, is my oncologist, when I went to my oncologist, I've got one main oncologist. I haven't seen her for about 12 months. I've been seeing other people at the practice, at the hospital. Turns out one of the oncologists resigned, so I was seeing other people. And I finally got to see my original doctor 2 months ago. So I can now ask her to do, take me off stuff, because the other people weren't too sure what to do. They'd always say, "Are you still in pain? Why are you still in pain?" Like, no, look at my x-ray. The last person I saw, he gave me endone. He gave me 180 tablets in one shot, which put me which blacklisted me from the healthcare. So it makes it really difficult to get endone anymore. But we managed to get it.
Thanks for that, Rod. Anyone like to ask Rod a question?
Jim here
or
now.
comment?
Just with a comment that may be useful to everyone. When time comes that you need painkillers, there are two types of painkillers. You'll be given a baseline painkiller, and the important thing about the baseline painkiller is that you keep taking it absolutely regularly. So it's very often when you start on the pain journey that the baseline will be paracetamol. That's Panadol or other brand names. And that's the baseline. And if you're on Panadol, you'll be taking 3 a day, and you'll try and keep that as close to 8 hours difference to spread it out evenly. So if you're not the sort of person who is up and down 24 hours a day like me, what some people do is they take the first one when they wake up, the last one when they're going to bed, and they work out what halfway between those two is for the other one. So whatever your baseline is, you keep it going as steadily as you can, and you do not give it up because you think, oh, I don't need it anymore. You know, everything's under control. Because if your pain gets out of control, it's harder to get back in control. So as well as the baseline, you have a breakthrough medication. The first breakthrough medication that often is paired with paracetamol is endone. And the idea of the breakthrough is that the moment you have any pain coming through, you immediately take the breakthrough. You don't be a stupid man, like we all are, unfortunately, and think, oh, you know, I can put up with this. I don't want to take too many drugs or whatever. But it's important that you hit any pain that arrives with the breakthrough as soon as it happens, because it'll be easier to bring it under control. So when you start out, as I said, you'll be taking probably paracetamol regularly, and then you'll be taking endone when that breaks through. And then when that's no longer enough, you've got to be careful to tell your doctors immediately. The first duty of a doctor is to check how your pain is going. So that'll probably be the first question they ask you. And make sure that you don't say, oh, you know, everything's okay, or I'm managing, or whatever. And if pain does break through, you'll have a contact person that you'll have been given, whether it's a nurse or a receptionist or the doctor or whatever, and you tell that person, you know, the pain is not easing off, and then they'll work through with you getting it back under control. But eventually you'll step up a gear, and the endone will become your regular one. That is your base one, and then you'll have a different breakthrough one, maybe Targin or whatever. The choice of drugs is up to the doctor, but it's important to keep it under control.
I think we should just point out at this stage that palliative care is different to end-of-life care. Palliative care is pain management care, not end-of-life care. So, some doctors think palliative care is end-of-life care. It's pain management. So, yes, Yanni?
Yeah, I was just going to ask, what does palliative care actually mean? I mean,
yeah.
the doctor and say I'm in pain, and he prescribes certain medications for you, then does that constitute palliative care, or is there a special regime that when you enter palliative care, you know, there's a raft of drugs that are specific to palliative care? care and a particular sequence of usage of the drugs or whatever?
Jim here, I'll answer that one. Palliative care is about treating the symptoms, right? It's not trying to cure a disease. So if a doctor's giving you something which acts against the prostate cancer, that's not palliative. But if they're giving you something to treat the pain, or you're having an operation on your spine to clear up problems that have arisen there, that they're palliative. That they're not treating the disease, that they're treating the symptoms. So palliative is symptom management. Thanks, Nev.
Thank you.
Thanks, Jim. Any further questions to Rod or Jim? If
Tony,
not, we'll... Yeah,
Nev?
go on. Yeah, Tony.
Thanks for that input, Jim. I was just going to ask Rod, has he made inquiries about radiation for pain management?
No. I went to the radiation place once. They basically said it was because I got it's on all the bones, or it's too extensive, so they said it would be too hard to manage. Similar to the chemo, they said because it's so much of it that I'd be on chemo for so long. I had a choice of what's it called? Quality of life over extending the life.
Okay. Well, that's unfortunate for you, mate.
Yeah, quality of life's important. Yes, Yanni?
Well, what about the lutetium treatments? The
that's in Sydney.
Nuclear medicine
and
treatment.
yeah, I was at the meeting the other night, but it's, as I said, it's in Sydney. It's pretty expensive. And the doctor, the oncologist hasn't mentioned it. I have mentioned it to the doctor, and they said they couldn't see a reason why to do it. And since I've been seeing my proper oncologist, I haven't queried him yet, but I will probably go down that path. It sounds pretty good, what I've been reading about.
Just
because you say it's...
Yeah, sorry, Yanni, I'll just wait a sec. Last week, I was on a Zoom meeting with the Advanced Prostate Cancer Access Alliance. It's part of the November.
That was the one.
Yeah, and they've made submissions to MSAC, and MSAC has recommended to the federal government that lutetium be approved. So it looks like it's going to, and it's from what they said, it'll only be a gallium-68 PSMA PET scan. They won't be an FDG scan, so I'm not sure why that would be the case. But anyway, Michael Hoffman was there and Louise Emmett were on the meeting, and there was only 10 of us all up on the meeting. So, but someone asked, will it definitely be approved by the government? And one of the women from Movember, or Advanced Prostate Cancer Alliance, said, well, it'll be a first if it's not approved by the government, because everything that gets recommended to the government is usually approved by the government. So, yeah, so that's what happened there. Yes, Jim?
Just to clarify that, it's not usually, it's always. There is a line item in the budget each year to pay for any of these things which get approved. So it is approved. Once it's been approved, once it's been recommended to the government, it always goes on. That's the first thing. The second thing is, even if it hasn't been announced, you can you and your doctor can still get it. It'll automatically be free and so on. Governments often like to make big announcements about these things, chasing votes, I guess. And that they watch news cycles to see whether it's the sort of news which should be in the empty part or whatever. So you're going to get it. You just have to apply for it.
Yeah, it won't be available in all centres, obviously, but it'll be available in a lot of centres for what they were saying. Yes, Shani?
So my understanding is that gallium PET scans are available at no charge now, a couple of them, and certainly, whilst I haven't checked lately, up until recently there were quite a few trials going on with lutetium in combination with other medications. So I would think it would be worth your while checking out if there are any trials in your part of the world that you can have access to that include lutetium on them. And if your specialist is saying he doesn't see any benefit in it for you, I'd go to another specialist.
John Dunkley here. Is lutetium, I understood it was only applying to hormone resistant prostate cancer. Are you suggesting that if you applied for it, it would also be relevant for hormone sensitive?
Well, my understanding is that they were a while ago doing trials for early in the piece of a men's prostate cancer journey, but I haven't followed that up in recent months. But it's certainly a research item that I would undertake.
Yes, yes. It is available through Peter McCallum in Melbourne.
I believe.
Yes, it is. And also in Perth.
Right, yeah. But normally I don't think people are going to rock up and get lutetium early in the piece at this stage. It's you've got to go through a process of other treatments before you get to lutetium, unless you're on a trial. So that'd be the only way you're going to get lutetium early in the piece at this stage. But lutetium is not going to be a godsend for everyone. So there's a bit of a misconception out there, I think, that lutetium is going to be a saviour. None of these drugs on their own are a saviour for everyone. Some people respond better than others to any one of these drugs. I've been on Eligard since April 2011, and I've known a lot of blokes that can't handle Eligard at all and suffer horrendous side effects from it. So we're not all equal in that regard. Yes, John?
There is another PSMA similar to Letitia. My oncologist told me about it, possibly even more effective, but it's a similar approach. It only kills the cancer. But you're right, it's not a magic bullet for everyone. The other thing I understand is that you do have to have an FDG scan because that shows whether it will be helpful in your situation.
Yeah, that's exactly right, because there a few years ago when lutetium first came out, there was guys paying $10,000 just getting a gallium-68. They weren't getting an FDG scan, and they were wondering why after a couple of infusions they weren't getting any benefit, and that's because they had problems that an FDG scan would have showed up that the gallium one didn't. So, but the other night they didn't say that there was going to be an FDG scan, which sort of surprised me. So, but anyway, we'll just have to wait and see about that. Welcome, Alan. Happy birthday. Yes, Jim?
Oh, I was just waving to Alan.
Oh, sorry. Yeah. So you got anything else to add, John, or John Dunkley? Oh, sorry, John Basuma. Yeah, go on, John.
No, that's all right at this stage.
Yeah, thank you very much. Righto, John Basuma.
Yeah, it's John Boomsma, actually. I was a bit confused.
Sorry.
Just back to the endone question. whenever I take even just one, I become terribly constipated, and that's unbearable. I was just wondering how others manage that.
Yeah, I could make a quick comment. Having been there with back surgery, you're dead right. You've got to, before you use it, you've got to be using heaps of Coloxal or possibly Movicol, which are really there to prevent that problem. It's inevitable with, with opioids. I had the problem, and I was in a hospital where they wouldn't, the nurses wouldn't provide it without the doctor's approval, and that was over a weekend, and that was bad news.
Thanks, Alan. Thanks, John. Steve, Steve from Adelaide, would you like to tell us a bit about yourself, please?
Yeah, right. Thanks. Yeah, my journey's fairly short, I suppose. In this whole process, just starting out. So I'm interested to just see what the future might hold. Yeah, I'm 66, diagnosed about this time last year. Had the biopsy and Gleason score of 9. And the PET scan showed it didn't seem to have spread that they could detect. And so I then proceeded with the operation, the prostatectomy, which was in late October last year. My original PSA was around 14 or 15 back in May. After the operation, they dropped it back to 0.07, but then the subsequent months earlier this year, it was going up again. So then started radiation treatments, 32 daily sessions. Yeah, had the recent, about 8 weeks later, the PSA was then down to 0.04 after the radiation treatments. So now they're just playing a waiting game. I said come back in another PSA test in 6 months, but I suggested maybe prefer to do it in 3 months. So yeah, yeah, that's basically my history. And as I guess, I mean, certainly in the early stages compared to what a lot of other people here have experienced.
Just personally on the PSA test, Steve, I'd prefer to, in your situation, I'd prefer to have it every 3 months too, because yeah, 6 months is a long time to wait, I reckon, when you're new to this and you just lack that bit of confidence where you're going.
Yeah, particularly it was after the prostatectomy. Yeah, it was rising again fairly quickly.
Yeah. Yeah, mine rose straight away after radical prostatectomy, so it did. Yeah, Jim, did you want to say something?
Yes, just for other people who might be watching this, and perhaps for Steve, for most of the last 14 years, I've had a PSA test every month. I had to have a blood test every 28 days, and my doctor just always ticked the PSA as well. First of all, I'll comment on the Gleason score. The Gleason score, or the newer replacement for it, the 1 to 5 score, they tell you what chance there is that the prostate cancer will come back after treatment. They tell you what likelihood there is that you'll have metastases, and they tell you what likelihood there is that you'll die of prostate cancer. Now, these are only likelihoods. They're like odds. If you've got a high Gleason score, it's just more likely that these things will happen to you, but it's not guaranteed. So don't panic. On the radiation, it's fairly common that radiation oncologists would ask for your first PSA to be after 6 months. The reason for that is that the sort of radiation you've had, the general radiation, doesn't usually work immediately. It starts working sometimes around 6 weeks, sometimes about 6 months, and in some occasions after 6 years. Basically, people imagine radiation is burning the cancer, but it's not at all. The cancer cells stay there. It's just that all of our cells in our body replace themselves after a period of time, except for those in your heart. They use a little bit at the end of the DNA in each cell to do any repairs of any damage that's been done before they replicate, before they copy themselves. And what happens with radiation is that that little bit of DNA that little bit at the end of the DNA is damaged, so the cell can't replicate itself. So in other words, it stops growing. I guess that's a good place to stop. The damage happens mostly after 6 weeks and mostly within a year and a half. But it will continue. The cells will be sitting there. They won't be producing any, they won't be madly replicating. They won't be growing. So I'm not sure they've made that clear enough. Thanks, Nev. Thanks, Steve.
Thanks, Jim. Alan, you want to say something?
Yeah, thanks for that. Steve, I think you're not on your own with recurrence. I had prostatectomy also, which looked to have had clean margins, but and no apparent lymph node involvement in the pelvis. But in the event the PSA didn't drop, and after a year it started rising steadily, as you've had experience of. I was just a bit interested in the kind of radiation. I mean, I guess following on radiation from the surgery implies that they're checking that there's no residual cancer in the prostate bed. Whether they did any imaging to check that there actually was prostate cancer there or not, I'm not sure. The other option these days would, I think, be stereotactic radiation to attack any visible, image visible residual cancer. But that's, maybe something to keep in the back of your mind if you're talking to your radiation oncologist. Again, stereotactic radiation, or SBRT, is a pretty well established technique nowadays. And if you happen to get recurrence elsewhere, which is localized, it could be in a lymph node somewhere. And with Gleason 9, that's a distinct possibility. Keep in mind that's a nice, a nice targeted bit of spot welding that's available to you. With regard to other things, if you've had that sort of history and you get recurrence, it's almost certain that you'll graduate to hormone treatment. ADT, or androgen deprivation therapy, as it's called. If and when that happens, there's a whole lot of stuff you need to know. One of them is it's very important at that point to get a bone density test if you don't already have those regularly. Regularly typically means every 2 years. And you can get an order for that from your GP or from your urologist, either one. I recommend you at your age, if you haven't had it, get it done, because ADT tends to have a few side effects which you may have been reading about or heard about, and you need to be ahead of the curve to avoid them. There are things you can do with maintaining bone density. You're obviously aware of calcium and vitamin D, which, you know, at your age you probably should be using anyway. It's certainly important if you have hormone therapy. So just a couple of points. And the other one is, I'm not sure what your exercise routine is, but this is a really important time to keep a solid exercise routine going, both aerobic, where you're blowing a bit, and also resistance exercise, where you've got to pull on weights or elastics or whatever. So if you haven't thought about that, or if you're not exercising in some other regular way, this is a hell of a good time to start doing it. And just force yourself until you're into a habit. Once you're into a habit, it becomes quite easy. First 3 or 4 weeks are the tricky period for that. And finally, is diet. If you are a devourer of a lot of red meat, particularly processed meat, like, you know, some of the European sausages and bacon, things like that, it's probably a good time to stop using those. Plenty of other protein sources, including meat sources, that you can use. Probably a good time to go easy on the dairy. There are other alternatives for that. So I think once you start to take a proactive approach, that'll help. Very important also to get a copy of your any records of blood tests. You can ask for those. You're entitled to have them through the Privacy Act, and your GP can print them off for you, or your urologist, either one. They'll both have them. The same thing applies to any imaging that you've had done, and PSMA PET in particular. Get a copy of the report and just have a look at what questions that's going to generate for your treating doctors, because the more you can educate yourself on the disease you have, the more positive you'll feel within yourself, and you'll feel some empowerment as a result. So a whole lot of things there. Sorry to go on for a bit, but for a relatively new high-risk patient as you are, you're certainly eligible to be on this group. Great to have you, and yeah, keep coming.
Thanks, Alan. Yanni?
Just a follow-up comment to what Kim said about the monthly pathology tests. I've been on this road for since 2011, and I've been getting pathology tests monthly. And the reason why I get them monthly is because, as Kim says, being ahead of or as Alan as well said, being ahead of the curve is of great benefit, I think, because, you know, I've plotted an Excel chart, and I can see how all of my various markers are travelling. For instance, you know, alkaline phosphatase, which is one of the standard measurements, is typically elevated to and reasonably rapidly elevating if the cancer is spread to the bone. And I just monitor that, monitor my PSA, monitor my testosterone levels, cholesterol, all that sort of stuff. Cholesterol is important because the cancer can, if it's deprived of testosterone, the cancer can start converting cholesterol into testosterone by itself. And just keep tabs on all of those things. And if if you have a reasonably friendly GP, as I do, every time I see him, because I have a 3-monthly injection, I ask him for a handful of pathology forms, and he happily prints those out. adds either he adds my name to the list of recipients of the results, or I add my name myself, because the pathology people don't know who's added the name, and so you can have the pathology report directed to you via mail or email, and as a result, you know, you sort of got much more of a clearer perspective of where you're heading. And you know, I too was diagnosed as a Gleason 9, and here I am, you know, pushing 14 years into it. So you know, when you're newly diagnosed, it's very easy to think the end of the world is nigh. But let me assure you that your travels on this not so fun road are you know, just at the beginning of where they're going.
Thanks, Jani. Any questions or comments, Steve?
Yeah, just with the radiation therapy, I think what they were basing the treatment on was that I had positive margin on the biopsy, or the prostate operation, and I guess that was pointing to the prostate bed area, which is fairly common, I understand. But they also did zap the couple of lymph nodes in the pelvis as well, I believe. So I think it was just a standard sort of precautionary attempt at trying to hit anything that might be around.
What's your exercise pattern currently, Steve?
I'd like to be doing a lot more, but
Join the club.
yeah, well, we've got
the reason I'm asking is that I'm detecting you're a little bit flat, and there's absolutely nothing like lifting your mood than exercise once you can start doing it regularly, particularly aerobic exercise. So I absolutely would put that at the top of my list if I were in your situation. And I've been managing, as Yanni said, in my case, I've been managing stage 4 prostate cancer for 21 years, right? So you've got a way to go, mate.
Yeah, if I'm feeling a little bit flat, I think I've had a bit of a cold or flu over the last couple of days. So.
Mm-hmm. Okay.
But also the weather has been dismal, as it has in probably most of southern Australia. But,
where are you located?
In Crafers, Adelaide Hills.
Okay.
And it gets
nice
pretty
part
cold.
of the world. So it is. John Dunkley, did you want to say something to Steve before, or did you have your hand up to say something? Oh, right. all good, all good. Yes, Tony Sheehan.
Yeah, can you hear me?
Yes, Tony.
Just a question to Yanni about alkaline phosphatase. What's the abbreviation for that in the blood test?
ALP.
Say again?
ALP.
ALP. Got it. Thank you.
Thanks. Yes, Jim.
It's sometimes SALP, serum ALP. Yeah,
it's just ALP on my blood test request forms, so it is. Dave Southwood, would you like to tell us a bit about yourself? Or?
Yep, no worries. Can you hear me all right now? Yep.
Yeah, good. Coming through loud and clear.
Cool, no worries. Yeah, so I was diagnosed last March with stage 4 prostate cancer, which has spread to my pelvic bones and spine. At the time, my PSA was about 27. So initially, they went pretty hard. They did some radiation to my, mainly probably because of the pain I was in. They did some to my spine and my pelvic bones. So that was like a week long. And then I went into 6 rounds of chemo pretty much 2 weeks later. They went pretty hard just because of my age, and they thought, well, we may as well go hard with this because I was pretty fit. And I'm also on the Eligard hormone injections every 6 months and Nubeqa darolutamide tablets. At the moment, the plan was to do radiation to my prostate, but it's been, I had a good sort of reaction to the treatment, and there's been no new cancer, and the existing cancers decrease in activity. So the radiation to the prostate's been sort of put off a couple of 6 months on occasion now. So since my next appointment with the radiation oncologist is in November. So the chemo oncologist is pretty much managing me at the moment. I get a PSA test every 2 months and all the rest of it. I've actually got to have the Prolia injection next Thursday because my bone density's gone down from the hormone therapy. So, which is, yeah, so that's a bit of a bummer, but hopefully that'll help. But I do keep pretty fit. I've got a PT. I was a keen runner before all this happens. I'm just starting to get back into some more running now as well because I fractured my foot. Stepped off a ladder awkwardly a few months ago, and I'm just sort of recovering from that. And then I've had to have all this dental work so I can have this Prolia injection. So probably should have kept that up to date. So that's my own fault, I guess. But yeah, so it's not going along too badly at the moment. It's just dealing with the side effects from the hormone treatment, I guess, is the main thing. And yeah, life's not too bad.
Thanks for that, Dave. I have a Prolia injection every 6 months, and I went to the doctor and got the results of the last one that I had done, and my bone mineral density is actually improved on the previous one. So, but I've been having Prolia injections for a fair while, and yeah, so it has arrested the decline by the looks of it, so which is not a bad thing. So how, do you mind if I ask how old you are, Dave?
I'm 55.
Yep. Right.
Yeah.
More and more common. Yes, Jim?
Yeah.
First, a question for Dave. Did you start the darolutamide, was it, near the start of your treatment or not?
Yeah, I pretty much went straight on to the darolutamide when I started chemo.
Okay, so that means that you're on the latest approved treatment, which is called triple hormone therapy, and it gives you the best chance of having longer life and greater quality of life. And it's covered by the PBS because there's evidence that it does that, you know, increases the length of life and the quality of life. So so anyone who gets diagnosed with METs when they start off, triple hormone therapy is what you ask your doctor about if they haven't mentioned it. The second thing is you've mentioned Prolia. Which is quite effective for bone mineral density, but it's not effective for delaying bone-related issues caused by prostate cancer. For bone-related issues caused by prostate cancer, you should have the other bone medication. Can someone help me with the name of the
Exgiva?
Because it's stronger, and it's the one that's been shown by research to delay bone incidences. So your doctor may have a special reason for prescribing Prolia for you because of other things that are happening. But some people take Prolia because it's a lighter dose and all that sort of thing. But the Exgiva dose, tell me the other name for Exgiva, somebody, please.
Denosumab.
Hey, denosumab.
Denosumab.
Okay, denosumab. Denosumab is the one which has been shown to delay bone-related events with prostate cancer. So you might want to check that there's some reason they're giving you Prolia instead. As far as diet goes, I think I'm talking to Steve or somebody. Diet is important before you get prostate cancer. After you get prostate cancer, it's not so important for the prostate cancer. Indeed, there are people who say that it's like Mark Moyad say that it's not important for prostate cancer. What it is important for is that even though you've got prostate cancer, other parts of your body will be trying to kill you, particularly your heart will be trying to kill you, just like everybody else your age. And their diet is important. The other thing is that if you're having trouble with constipation, there are some foods which will hurry things through your bowel. There'll be things which you've dropped off your diet because of looking after your heart and things like that. But fatty foods, fatty fried foods, will hurry things through your bowel a little. Dairy will hurry things through your bowel.
Dragon fruit.
It's a call you have to make as to and you might make it just temporarily, whether you might add those foods just to give it a little bit of extra help for things going through. And the final thing on that is your weight is important in the later stages of prostate cancer. So if you're losing any weight, or if you're in the later stages, where you're on to painkillers and stuff like that, then you'll be eating those things which were left out. You'll be having malted milks, and you'll be eating the batter from around the fish instead of taking the fish out of the batter, and so on. Thanks, Nev.
Thanks, Jim. Any other questions or comments to Dave? Yes, Alan?
Just a quick one on the bone protection. Jim mentioned Xgeva or as an alternative to Prolia. They're both denosumab, which is what you might call the generic name for this stuff. It's an injection, and the whole point is protecting your bones. And if you're having you're in a situation that you're in with existing bone mets, I would definitely have a conversation with your doc, your medical oncologist, about maybe graduating from Prolia to Xgeva. It's same stuff, but as Jim mentioned, it's stronger. And it's normally what would be used to protect you from damage to your bones caused by the bone metastases themselves. What you don't want with spinal metastases is spinal cord compression caused by a collapse of a vertebra, and that's the whole point of using the stronger version Xgeva. So I would regard that as a bit of a priority.
Thanks, Alan.
I have Xgeva once a month too.
Sorry?
Once a month for Xgeva.
Yes, Xgeva is once a month, Charles. Yeah.
Exactly.
Yes, Yanni?
So there's been no discussion about what I'm on. My endocrinologist, who I saw about my bone health, didn't want to put me on Prolia or denosumab or whatever. She put me on
Lamita.
No. Alendronate.
Alendronate, yes.
Fosamax.
Yeah, and that takes the form of a tablet weekly, and I believe it's weaker than Prolia and denosumab or whatever, but my understanding of all of these bone density improvement drugs is that it does tend to make bones more brittle, because the normal bone healing process is osteoclasts deteriorate or get rid of old bone material, and osteoblasts build new bone material. But these various treatments do not allow the osteoclasts to get rid of the old bone material. They just keep on building, and that makes your bone more brittle. So my endocrinologist, as I say, put me on I can't say that word.
Alendronate.
Yeah, and it has come in handy to be on tablets rather than on an injection, because in recent times first time I tripped over the dog, and I fractured a bone in my hand, and then the second time I was on a cruise, and the boat zigged and I zagged and fell over and cracked some ribs, and it was fortunate that I was able to stop the bone tablets to allow my fractured or broken bones to heal better. So I'm not quite convinced personally, but I'm not a doctor, as to the importance of, well, not the importance, but the preference to go to injections immediately.
Well, there's 2 points of view you've heard, so neither of us are offering you medical advice. All we're doing is suggesting a couple of topics you could raise with your specialist, and at the end of the day, you'll no doubt be influenced by what he says. So go for it.
No worries, thank you. I'll definitely have a chat to the oncologist next week about it all. Cheers.
Yeah.
Yes, Jim. Thanks, Dave.
So the greatest damage to your bones happens during the first year of treatment. My doctor put me on alendronate from the beginning, and here I am 14 years later, and practically everything in my body is not working the way it should. But I've got bones which are, well, there's 2 measurements that are taken in 2 different parts of your body. And in one of those measurements, I'm as strong as the average 18-year-old man. And in the other measurement, I'm stronger than the average 18-year-old man. So you might think about when you're seeing your doctor, you probably want the stronger, he'll probably want to consider the stronger dose earlier, or she, sorry.
Thanks, Jim. Any other questions or comments there, Peter? Peter Hall?
Question to Dave. How long have you been on darolutamide?
Pretty much since last April.
Since April. Have you suffered any type of side effects from it?
I think the main side effects for me are the fatigue. I feel like I'm getting like arthritis in my hand now. I don't know whether that's an age thing, but yeah, I've had some trouble with my hands.
Yeah, well, I'm on my 3rd second-generation drug. I've started on enzalutamide, then to Zytiga, and I'm now on darolutamide. And perhaps I packed my head into too many scrums as a young fellow, but I have great difficulty walking. I have great difficulty getting out of a chair. And I've only been on it for 1.5 months. So I've got another 2 months odd before I go back to see my radiation oncologist to work out whether it's actually helping with my PSA. I'm also on deferraline, so that I've been on that for 4.5 years. But it's only a recent switch to Nubeqa or darolutamide, and I'm finding, well, the tiredness has always been there for the last 4.5 years, but the darolutamide is really every broken bone, every broken tendon, snapped tendon is just playing up.
Thanks, Peter. John Dunkley wanted to ask a question, I think.
Yes, David, I'm just interested in, I gather the bone density issues because of the hormone treatment. So how long before you became aware that the bone density was being affected by darolutamide?
My oncologist only really sent me probably a couple of months ago to get a bone density test. So it's only been, a couple of months ago.
Right. So the effect on your bones has been fairly quick from the hormone treatment.
Yeah, well, I guess so. It's only been since last April. So
okay,
that's a quick one. It's not specifically darolutamide that's attacking bone density. Androgen deprivation, which is primarily it's both. It's the what was it, Lucrin or whichever one you were using. The 6-monthly one, Eligard, wasn't it?
Yeah.
That's probably the primary culprit. The other one, darolutamide, is aiding and abetting the problem. It's just depriving your body of testosterone that's the cause, and really, again, resistance exercise really good. The more your muscles can pull on the bone, the stronger your bone will be. So very important to get into resistance training. It also improves your mood. It attacks fatigue. It's got so many benefits that are there for the taking.
Well,
Thanks, Alan. Thanks, Dave. John, do you want to say something more? John Dunkley?
no, I can share that if I share my story.
Yep, thank you. Mark Godfrey, would you like to give us a bit of an update? Did you want to say something to Dave or not?
I was just going to comment on the darolutamide. I've been on it for 4 months now. I didn't really have any side effects from it at all, apart from the hot flushes got sort of worse the first month or so. But I mean, I'm back to having the electric blanket on at night, so that's obviously improved. But I thought I had a stomach issue from it, but it turned out they gave me a test and it was some bacteria that was in my stomach, so they gave me antibiotics for that. So it obviously wasn't related to the darolutamide. So but it definitely got the PSA straight down, because it was 4.5. The PSA was 4.5 when I started. The next month I had a test every month for 2 months, so it went down to, from 4.5 it went to 0.14, and I think the latest was 0.17. No, 0.4. It went, after the first month it was 0.49, and then the second month was 0.17. So it definitely took it down, and so I'm just waiting. The end of next month I get my next PSA test after the 3 months. So that's where I am at the moment. So just waiting for that PSA test in, what is that, about 5 weeks, just to see. Hopefully it's lasted longer than the Eligard did, because that didn't last very long at all, which is sort of strange, because my story and numbers were almost exactly the same as Steve's. My after the PSA after my radiation was 0.04 as well, which I think, Steve, you said yours was the same as well. Yeah, and then I didn't have my next PSA test for turned out it was like 5.5 months, and it was the 1.26 after that. So, you know, it was sort of, if you average it out, it was doubling once a month after that 0.04. So yeah, I would sort of suggest to Steve that, yeah, you sort of push for 3 months. Because yeah, I mean, I was quite happy with 0.04. But yeah, it turns out, you know, at least a 9, it can go up quickly if you don't keep an eye on it. So yeah, so that's all I really have to say.
Thanks, Mark. There is a small cohort of people that don't get a good result from Eligard or the first-line hormone therapies, unfortunately, it seems.
No, I think I'm the poster boy for that. So
no, you're not alone, unfortunately. But anyway, they are out there. I'd like to ask Dave a question. I think you said you have your Eligard injection 6 monthly. I'm just wondering, 6 monthly seems, I don't know many people that have their Eligard injection 6 monthly. I find that interesting.
Well, there are monthly, 3 monthly, and 6 monthly versions of most ADC drugs. Personal point of view, I have a bit of a bias against 6 monthly because it implies that the slow release is constant over that amount of time, the same for everybody. I have my doubts about that, but I've got no evidence for those doubts. I prefer 3 monthly, and there are various ADC options that, again, you can discuss with your oncologist. There's Zoladex, there's diferoline, there's Lucrin, Lucrin's, you know, so any of those are possibilities. I don't think there's a lot of evidence to say that there's much difference between them. So maybe just if you're uncertain about the durability of a 6 month injection, just say, look, I'm happy to have them 3 monthly. Can we switch? You're entitled to ask.
I was on the cancer telephone Zoom meeting, whatever it was, a few years ago, and there was a guy there, and he said he was having 6 monthly injections, and they all nearly dropped dead. And he said, "Oh, well, I live out of town a bit, so they said, well, make it worth your while to get in to have it every 84 days." So, but anyway, there you go. What would I know? I'm not a doctor. But anyway, I'll leave that with you, Dave.
I just thought it was less, you know, regular. So I thought, oh yeah, may as well just go the 6 month. It's a bit bigger needle actually, so it hurts a bit more. But
not so sure about that. But anyway, that's your decision.
Well, it seems to be. I think it seems to be working okay at the moment.
Yeah, well, I was on 3 monthly for a while when I first started. Then I went to monthly, and that was for a start it was 90 days, and then I went to monthly, and we got it down to 28 days. And I was on every 28 days for years. And then I'm thinking, I've been on it for that long. Why am I paying $30-something every 28 days? I might as well just pay $30 for every 84 days. So that's where I'm at the moment. So yeah, that's just a personal preference. Yes, Jim?
Alan said there wasn't, he wasn't aware of any evidence for this, but there is evidence that at the end of your period, whatever it is, if your PSA starting to rise because testosterone isn't being suppressed, that's called breakthrough. And some medicines that have been checked for this, one is Zoladex. Zoladex is very commonly given, and that's a good idea because most of the other treatments need to be carefully mixed, and you need an expertise in mixing them. They're like araldite or one of these, you know, mixtures. You've got to mix two things together. But what Zoladex is they mix the araldite in their factory and give you a little tiny grain of rice that gets injected and leaks out. And it has more breakthroughs than the diphthyramine that Alan mentioned a minute ago. On the other hand, diphthyramine takes more time to start off with, but that is to bring your testosterone under control. But once it's under control, it lasts for a very long time, which I was I'm counting as a blessing. I was in hospital for April and May, and I missed out on my prostate cancer injection. But when they checked the PSA, even though I hadn't had a proper injection for about 4 or 5 months, there'd been a mix-up in one of my injections. It wasn't properly mixed. My PSA was still undetectable. So the diphthyramine will keep it low for a long time. And a fairly common sort of injection is that they'll use Firmagon, which is a harsh sort of injection, just for the first injection to bring the testosterone immediately under control, and then switch to another kind of primary hormone therapy. And in Europe, that's diphthyramine. And so that's the way they treat. Oh, in most of Europe, that's the standard treatment. Thanks, Nev.
Thanks, Jim. Dave, just make sure that the Eligard does get mixed. I had a situation once where it wasn't mixed. I asked the doctor, he put me in one room and went to another room with the 2-part mix, and he was about to give me the injection, and I said, did you mix it? And he said, does it have to be mixed? Now, the only reason why I knew about that was because one of our other members had had that issue a couple of years earlier. So that can be an issue. So it can, in some cases. You can have Eligard injected in your own home. The Blue Nurses in this part of the world will do it. All you have to do is get your doctor to write a referral, and you send it off to the distributors of Eligard in Melbourne, and you can have it injected in your own home if that's your choice. Yes, I'll go to Mark first and then Ian. Yes, Mark?
Yeah, I was just going to say, with the Eligard injections, yeah, I get mine every 3 months. But yeah, when I was put on it, yeah, I didn't know you had to ask to get it injected by the Eligard nurse. I just assumed everybody had that, but I found out they don't. But yeah, I just get mine injected. She comes around every 3 months and injects it, and yeah, I've never had an issue with it. So
yeah.
And I don't have to go out anywhere, and I get to talk to a nurse every 3 months. So yeah, it's just made it really easy for me to get it done every 3 months. So she comes around, takes 5 or 10 minutes, and it's done. So I just have to just remember to go to the chemist and get the box just, before she gets here. So yeah, it just makes it really easy. And she knows what she's doing. So that, yeah, I haven't had any issues with it. I haven't had any pain from the injections or anything. So
I make sure I keep it in the fridge, obviously, and then before I have it, I bring it out of the fridge and bring it to room temperature before I have the injection. That makes it a lot easier to mix, and it doesn't sting as much when it goes in. So that's an important factor as well, I believe. I'll just come to you in a minute, Ian. We were to have Katie Owen with us today. Katie's a researcher from Peter Mac in Melbourne, and she wasn't able to make it again today, but she's desperately wants to talk to us, and she's going to be here in August. Now, we're a bit lucky in August. We have 5 Fridays in August, so if she can't come on the 4th Friday, she may be able to come on the 5th Friday, but she's definitely has it in her diary for the 4th Friday of August, and I'm sure you will appreciate that information that she gives us and tells us about her work, and she'll be available to answer questions during the course of her talk. Thanks, Ian.
Yes, I've got to leave today, so I'll catch up with you guys next month.
Righto, Ian. All the best. Thank you. You haven't got a quick update for us or anything?
No, I
No.
will have no, not next month. September the 10th is my next specialist appointment.
Righto. We'll catch you then. All the best. Mark,
Okay.
you wanted to say something else?
No, I was just waving to Ian.
Ah, right. Sorry. Righto. John B in Melbourne. Are you like to give us an update? Are you right to go?
Yeah, sure. Where do I start? So Gleason scored 9 7 years ago. I guess if I fast forward about 4 or 5 years ago, after the similar story with radical prostatectomy, PSA started going up, 32 radiations, then some more, and then eventually they said it's like Pokemon, you're going to go on ADT. So I started on Zoladex 4 or 5 years ago, 3 monthly, or 84 days after your advice. And that lasted about 2.5 years before I started becoming castrate resistant, and then went on to abiraterone, which I've been on for now a little over 2 years, before my so about 9 months ago my PSA started climbing from, it was around, it held for about around 0.5 for those 2 years, and it had jumped to 2.5, 2.6. And my oncologist said we might get a little bit longer out of abiraterone by putting you on Dex, a steroid. And he, at the time, thought it might only be 3 months, but it feels a little miraculous for me that I'm now at the 9-month point. I had a test last week, and it's still at 2.5. So it's been holding at that level. It hasn't gone down, it hasn't gone up. But, my oncologist, both my oncologists were fairly impressed with that. So I'm pretty happy about that. The side effects of the steroids aren't so good, insomnia and weight gain and all those sorts of things. But if it's keeping me alive, it's worth it. I guess the other piece of information, I suppose, is that I've been seeing a private oncologist at Cabrini who I wasn't all that happy with, and I'd always been getting a second opinion from Declan Murphy at Peter Mac, and I went and saw him 2 weeks ago, and basically I'm switching over to Declan being my primary caregiver. He's not an oncologist, but his team. I had a bone scan because of the issues now around limited PSMA PET scans in terms of funding, 2 in a lifetime apparently. Declan told me. So I just had a regular regular CT scan and a nuclear scan, and I'll get those results next week. So that's where I'm at the moment. I do have a question for the group. I don't know if no one's mentioned abiraterone, but I've been breathless, even though I do a lot of exercise. It's been a real problem for me. And I haven't been able to diagnose what the cause is. I've had, comprehensive heart and lung tests, and they've all come back quite positive. But I was just wondering if anyone else suffers from breathlessness as a result of, I'm assuming, my medication treatment. Yeah, I think that's about it.
You got a comment on that, Alan? You're on abiraterone, aren't you? Or have been?
Yep, sure. Just a question, John. You mentioned that you had added something to the abiraterone that gave you stable PSA. What was the something? I missed it.
Steroid
dexamethasone, was it?
Yes, yeah.
Yeah. So
2 milligrams a day.
Yep. So I'm also using that and Zytiga. I've been using Zytiga for many years now. I did go off it for a while, and in fact, I went off all my cancer meds because the PSA had dropped down to 0.01. And after a year or two on that, I thought I'd try and duck some of the side effects. So, but the tiger jumped out of the cage pretty smartly, so I went back on it again. But dexamethasone is a steroid which is an alternative to the more commonly recommended prednisone, which was the steroid used in the original abiraterone or Zytiga trials. And its role, and the role of any of these steroid options, prednisolone is another one, is to avoid changes in your blood potassium level, and also increase in blood pressure, so to control those side effects that tend to be associated with abiraterone. You don't need much. I think my dose is something like yours, quite low. Steroids do tend to, like the ADT options, they tend to attack your bone density also, quite independently of the other things that are attacking it, not least age. It's important, as I mentioned earlier, to keep a resistance training component in your exercise plan. Keep the big muscles pulling on your bones. Keep the vitamin D and calcium going if you aren't already. Just keep an eye on any a couple of items in the blood test results, that one or two of which have been mentioned already. So keep an eye on your blood tests. ALP is one that you want to watch, and there are a couple of others that are important as well. So that's it from me.
Thanks, Alan. Appreciate that. Any other questions or comments to John? Righto, all the best, John. Good to have you with us. Everybody shifted around in a different spot on my screen. I can't catch up. John Dunkley, have you got anything else you'd like to say or add or ask or anything?
I'll just fill you in with my diagnosis. I was diagnosed at Christmas time. Gleason 9, high volume metastatic cancer in the ribs and lymph glands and around the pelvis, and obviously in the prostate. So they put me on the triple therapy with Nubeqa and docetaxel. I've just finished 5 rounds of docetaxel. I've got a bit of peripheral neuropathy on my feet, so he probably is going to leave the number 6 one, which I'm actually happy with. So I'm finishing. That's finished chemo. My PSA is 0.04, and the testosterone obviously is rock bottom. So I'm waiting on a scan. I was keen on getting another PSMA scan because that seems the most accurate one. I'd like to see what's happening in the prostate as well, but it's probably unlikely. And I heard a comment there. Did someone say you only get 2 per lifetime PSMA?
Oh, you can have it. You can get them more as long as you pay for them.
Right, pay for them. Yeah. I've really struggled on the hormone treatment in terms of how fatigue and emotional regulation. That's been a huge battle for me. But from that, I'll just be waiting on the scan and seeing how that goes. I exercise regularly. I go to the gym and do weights, and I also do running and walking. I have been under chemo, I think. I've struggled with breathlessness, so I only just run for a short bit and then I walk, and then I run and walk. But I've tried to keep up the exercise. That's about it. Nev,
Any questions or, sorry, yeah, any questions or comments to John?
Sounds like you're doing most of the right things, John. Yeah, I think hang in there, mate. Keep that exercise happening, as best you can. I haven't heard of breathlessness specifically as a side effect of the sort of treatment you've had. So yeah, go for it.
Thanks, Alan. Yes, John.
I mentioned there's an alternative to lutetium-177. It's called actinium.
Actinium-225, yeah.
Yeah, and my oncologist suggests that may even be more effective. But again, it's availability. I wanted to do lutetium-177. I didn't want to do chemo, but while my cancer is hormone sensitive, it wasn't going to be available in terms of a trial, and the expense is very costly to have it otherwise.
Well, that's not 100% true. The expense, if you get it done through this other outfit that does it privately, it's expensive. But whereabouts do you live again?
Adelaide, but I'm willing to travel.
Yeah, certainly in some states, Peter Mac is obviously the best known one that's available elsewhere, St Vincent's and other places in Sydney. But eligibility is an issue, and you've got to, I think what treatment you're on now is what I call standard of care, what the doctors call standard of care. It's representing the most up-to-date trials that for someone in your particular situation. So I wouldn't knock the fact that you've been on the chemo first. Anyway, with the radiopharmaceuticals like lutetium or actinium, and there's another one, lead, and there's another one with copper. They're all different isotopes that can, with the right carrying additive, if you like, attack cancer where it is. That's pretty much going to be dictated by PET scans. You've had no PET scan at all yet?
Oh yes, no, I've had the original PSMA PET scan, and I had an FD scan because they were looking at whether I was eligible for a trial at Peter Mac.
Okay, that's clear. And did you earlier on have an MRI scan?
Yes, I had an MRI.
Yeah, that's clear. Yeah. So and the more recent PSMA PET that you had was what was the PSA level at the time, roughly?
My PSA level was about 5.5, so it was quite low. The only reason I had the MRI is
that means it's perfectly detectable by PSMA. And where was it showing again? Where were you getting?
So I've got it in my pelvic area, top of my thigh bone, femur, and in my.
Yeah. So all the commentary that we had earlier in this discussion about bone protection is absolutely relevant for you. If you haven't had a conversation with your docs about denosumab, maybe, or Zometa, or one of the other bone protection, injections or tablets, I think maybe you should.
Yes, I had a bone density done early in the year just to see what it was. They said they'd leave it for 12 months, but after listening to this, I would be interested in finding out more.
There's a distinction, the real important distinction between bone density and damage to the bone that can be caused by bone metastases. Two totally different things. If the metastasis burrows in and particularly in the spinal area and starts to weaken the bone, you can have a collapse which affects your main nerve center in the spinal cord, and that can disable you completely and shorten your life. So very important to protect your bones from bone mets.
Yes, Jim?
Just a short one. Our experience in the past has been that if you are given PET scans as part of a trial, they don't count against you. So that's likely to be the case still. So you've still got a PET scan available to you at government cost, I would think. But your doctor,
Charles.
So is that absolute? Is it just 2 PET scans? PSMA
Gallium
PET?
68. We're talking gallium 68 here mostly.
Yeah.
What's that?
A gallium 68 PET CT scan.
Yeah.
It's a little bit more technical than your just ordinary scan.
Okay.
So you'll know if you're having a gallium 68 scan.
A PET scan, a
gallium, it combines 2 things. So it is.
A PSMA.
Yeah.
Is there any? Is that 2 of those a lifetime? It doesn't include. Does that include? There's no discount for pensioners or any other thing.
Not that I'm aware of.
Okay.
Jim here again. I'll look it up after the meeting, but I'm pretty sure you can have 3. One is initial investigation that you can have, and then ongoing treatment is 2 per lifetime. So that turns out under certain circumstances you can get 3. But for many people on this call, they're in the ongoing ongoing treatment 2 limit. But if you're counting one that you had initially to see what sort of treatment you should have, then you've still got 2 to go.
Okay, thanks.
Thanks, Jim. Now, we're running a little bit over time, so I'd just like to give Paul and Peter the opportunity if they want to say a few words. We'll go with Paul first and then Peter. Paul?
Yeah, thanks for all the valuable information. It's really a mind, it's great to have all that extra knowledge. So I really appreciate it. Yeah, I've got my 19th radiation session today, so I've got number 20 on Monday. So that'll be my last, and then I see my medical oncologist next Friday. So I'm going to be getting my PSA test and some other tests prior to seeing him. Yeah, so no real side effects. I mean, I've had a bit of a cold, so I've just been a bit tired anyway. Yeah, so it's gone pretty smoothly. I'm finding my wife is struggling with getting information from her doctors, and that may not necessarily help her state of mind. As in, has he got stage 4 cancer? So just reminding her, and without any other background behind it, So I find that it hasn't been helpful, but so yeah.
In 10 years time, Paul, she'll be wondering what she was worrying about.
Yeah. I'm doing we've got access to a medical, it's called Medical HP Med. It is in Melbourne, HP Med program for 12 weeks. So it's resistance training and aerobics training and exercise physiologists. So, and that's free of charge. So that's great. I mean, I think I'll continue doing that after the 12 weeks runs out. Yeah, and I'll continue to doing all my other exercise except for this week with the cold. I just noticed I had a bit of a soreness in because I've got, so mine was just to remind you, mine was in the prostate, and then it got into the lymph nodes, I think, tracking along the spine, along the back, if that sounds right. And I've just noticed so it could be related to the exercise, but I've just noticed some soreness in my back. But I'm doing some exercises that I wouldn't have done before. So I just asked the nurse if that was probably related to the exercise rather than anything suspicious going on with the lymph nodes or anything.
Yeah.
Yeah, and the other thing is just diet, and you've answered all those questions. So so just once again, thanks for all the info. I appreciate everyone's sharing.
All the best with the radiation. Any questions or comments to Paul?
Quick comment. I don't think the lymph nodes, if they are affected, would cause you any discomfort. Bone mets, on the other hand, probably would. So you do need to keep an eye on that possibility with scans. There are even other, depending on whether you can afford PSMA PET if you run out of eligibility. Depending on how high your PSA is, even the old-fashioned bone and a bone scan with what they used to use in conjunction with CT can be helpful. So it's just something to explore. But if you've got ongoing pain that increases in severity, certainly worth a check.
Yeah, it just feels like a bit of just muscle soreness, and yeah.
Well, if it's muscle soreness, it generally be slightly to one side or the other of your spine. If it's bone, you'll know where that is. It'll be in the middle. So it could be in the ribs, which obviously aren't in the middle. So if you can press in an area of your muscle there and you get a response, then you're probably okay. But just keep it in the back of your mind.
Yeah.
With regard to your wife, it's important that partners don't get overlooked in this journey. You're in Melbourne. Whereabouts are you?
So Black Rock. So we go to the Icon Cancer Centre at Holmes Glen.
Yeah, right.
Which is in Moorabbin.
You want to just check around. There are some really good support groups that cater for partners and partner support. It's a bit hard for this group to do that because it tends to be a bit more focused on the guy and his symptoms. But that's just something to explore. In the group I'm in, not in Melbourne, but it's got a fantastic partner group, and partners come to the main meetings like this one as well. So you don't ignore that. It's partners get a rough deal. They do.
Just yes, John.
Yeah, there's a really good PSFA support group in Black Rock, I think, or very close to Black Rock, that might be helpful.
Absolutely.
Alan White and his wife is also very involved in that, and I'm sure they would be able to support both of you.
Yep. Good suggestion.
Do you have Mark? Do you have ladies in your group down in Adelaide?
We had the first meeting we had. We've only just had the second. Someone came along with their wife, and the next meeting, we've opened it up to the partners because the guest speaker we've got is one of the clinical researchers, I think, at Genesis, where they let us use one of their buildings in Adelaide. So they're going to give us a tour around the clinical trial room, which is on the 3rd floor of where our meetings are. So yeah, all partners can come to that. I think the first meeting we sort of decided, we weren't real sure. But yeah, I mean, if partners want to come along, because we do understand, a lot of the stress, is on them as well. So, and they want to know. And a lot of times I know from my own experience, with going to the doctors and oncologists, half the time I'm in a bit of a blur, and they'll think of questions that, I don't, and vice versa. So, I think it's definitely important to do it as a team, I guess, and try to do as many things.
Good on you for starting that group anyway, Mark. All the best with it. Yanni?
Yeah, thanks for that. It's going well so far.
Yes, Yanni?
Oh, sorry, Yanni?
This is probably a little too far for you, Paul, but anyway, I'm a member of the Heidelberg Prostate Group Forum, and we regularly have ladies attend, and that works out well. They also have a Zoom dial-in capability if that's more convenient. But there's quite an active participation of ladies in that group. The other point I'd like to make is that, particularly to the new guys, some of the prostate cancer gurus out of the States, like Mark Moyad and whoever else, they suggest that guys like us start using statins like Crestor to keep the cholesterol levels down, because, as I said before, the prostate cancer can start to convert cholesterol to testosterone. And the other one that they suggest is metformin, which is generally used as a diabetic treatment, but it's arguable that it provides beneficial capability to people like us. And I've been on that for, I don't know, about 7 years with no significant downsides. The only thing is that that it does keep your weight down, and it does possibly keep your vitamin B12 levels down. So you have to take I have to take vitamin B12 supplements. But you might want to give thought to those.
Thanks, Johnny. We'll go to Peter, and because we're way over time. Peter?
Look, mine can wait until next time, Nev. I mentioned most of it today before with, I'm feeling like I've been run over by Jonah Lomu every day. So, I can talk about the rest of it next time.